Welcome to this presentation on the MEND exam, a stroke assessment tool for nurses in the emergency department and hospital. I am David Lee Gordon, professor of neurology. One of the earliest stroke assessment tools for EMS personnel was the Cincinnati Pre-Hospital Stroke Scale. It consists of three components: speech, facial droop, and arm drift. For speech, you ask the patient to repeat, "You can't teach an old dog new tricks." For facial droop, you ask the patient to show their teeth or smile. And for arm drift, you ask the patient to hold out both arms with palms down, eyes closed, and you observe if one or both arms drift down, suggesting weakness. This scale has been repackaged for the public as FAST, face, arm, speech, time, with the addition of last known well for the patient to help determine whether a patient is eligible for acute therapies. EMS performs this scale on scene under D after AVPU. So they do A, B, C, D, airway, breathing, circulation, disability, and that's when you do this scale. And most paramedics or most pre-hospital providers in the country use an AVPU assessment tool for level of consciousness, alert, verbal, pain, and unresponsive. The Cincinnati Pre-Hospital Stroke Scale is very brief, only lasts 30 seconds, and it determines if a stroke is possible. In other words, likelihood of stroke, but it does not actually assess stroke severity and is not definitive. The NIH stroke scale is the commonly used standardized exam that physicians and other providers use in the hospital. The NIH stroke scale was designed for acute ischemic stroke clinical trials. It is reproducible, quantifiable, but it does require speech and language cards and a safety pin. The good news is the acute score has good correlation with the size of the ischemia in the brain, the core infarction plus the penumbra. And the chronic score correlates well with the CT infarction size. The admission value assesses severity and prognosis. If someone's admission NIH stroke scale score is greater than 10, they're more likely to be discharged to a rehab or nursing home. If it's greater than 15, there's a poor prognosis if they don't receive treatment, and if it's over 25, they have an increased risk of post-thrombolysis hemorrhage. However, the NIH stroke scale, in my opinion, is not useful as a daily assessment tool for a couple reasons. Number one, the values fluctuate day to day during acute hospitalizations, so each value, it's really more important the admission value to tell you how bad the initial stroke was, and then a repeat value 3 months to a year later to determine how much improvement. But those values during the hospital, which vary day to day, are not that significant. In addition, the NIH stroke scale takes about 7 to 10 minutes if you include the grading time, and that's too much for a nurse, in my opinion, too much time for them to take when they got all these other responsibilities for the patients. Consequently, several colleagues and I developed the MEND exam, or Miami Emergency Neurologic Deficit exam. This exam is modeled after the NIH stroke scale and incorporates the Cincinnati Pre-Hospital Stroke Scale. It's a practical exam for EMS en route, if they have time, and nurses in the hospital. It does not require extra tools, and it's for all patients with focal neurologic deficit, not just stroke. It's quick, takes less than 3 minutes, and there's no scale for EMS and a simple scale for nurses. It facilitates EMS and ED communication because EMS and nurses perform the same exam. The components and terms are the same as NIH stroke scale, and provides physicians with some data regarding stroke severity, unlike the Cincinnati Pre-Hospital Stroke Scale. For nurses, comments section is really important. For abnormal findings, always document the explanation and change in severity from the last exam. This is a summary of the MEND exam. You may wish to pause now and review it prior to the instructional videos. This is a summary of the MEND exam with responses from a patient who has a normal neurologic exam. You may wish to pause here also for a moment prior to reviewing the MEND exam training videos. Here's a proposed checklist for nurses to use when performing the MEND exam in the emergency department or in hospital settings. It includes ample area for comments and a simple scale. For level of consciousness, just observe the patient.
My name is Julianne. What's your name?
I'm Lynn.
For level of consciousness, document one of the following: awake and alert, or arousable to verbal stimuli, or arousable to tactile stimuli, or responds to deep pain stimuli only, or does not respond to deep pain stimuli. To assess speech, ask the patient to repeat, "You can't teach an old dog new tricks."
Repeat after me. You can't teach an old dog new tricks.
You can't teach an old dog new tricks.
If speech is abnormal, document the reason. Either aphasia if the patient says incorrect words, or dysarthria if the patient has correct words but slurred speech. For further assessment of mental status, ask the patient 2 questions: the current month and the patient's age.
Tell me the current month and your age.
May, and I'm 56.
If the patient's response to questions is abnormal, document one of the following reasons why: mute, aphasia, confusion, or depressed consciousness. Continuing the assessment of mental status, ask the patient to follow 2 commands: open your eyes and close your eyes.
Close your eyes. Open your eyes.
If the patient's response to commands is abnormal, document one of the following reasons why: aphasia, inattention, or depressed consciousness. In assessing facial droop or facial strength, ask the patient to smile or show you her teeth and observe whether both sides move equally well, or conversely, whether the lower half of one or both sides elevates poorly or droops, suggesting facial weakness.
Give me a big smile. Good.
If the patient's facial strength is weak, document which side of the face is weak: right, left, or both. When assessing visual fields, ask the patient to look at your nose. With your hands held just below your chin and palms facing inward, wiggle fingers on one side and ask the patient to tell you which side is moving, or to point to the side that's moving. Repeat this on the other side. With your hands held just above your forehead and palms facing inward, wiggle fingers on one side and ask the patient to tell you which side is moving, or point to the side that's moving. Repeat on the other side.
Now look at my nose and point to the side that's moving. Point to the side that's moving.
If a patient's visual fields are abnormal, document the side of the loss, right, left, or both, and document the area of visual loss: hemianopsia, upper quadrantanopsia, or lower quadrantanopsia. When assessing horizontal gaze, place your finger on the patient's chin to stabilize it. Then ask the patient to look at a finger on your other hand and move your finger all the way to each side, right and left, and observe if she is able to move both eyes completely to each side. In the normal patient, whites of the eyes disappear in the direction of gaze.
Look at my finger and follow my finger.
If a patient's horizontal gaze testing is abnormal, document the direction in which the patient cannot look: right, left, or both. When assessing motor arm drift, ask the patient to raise both arms in front of her with palms down and eyes closed. Observe for 5 seconds to determine whether an arm drifts down, suggesting weakness.
Can you raise your arms like this? Now close your eyes and keep them there. 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000. You can put your arms down.
If arm drift is abnormal, document which side is weak, right, left, or both. When assessing motor leg drift, ask the patient to raise one leg at a time with eyes open. Observe each leg for 5 seconds to determine whether the leg drifts down, suggesting weakness.
Now can you raise your leg up and keep it up? 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000. You may put it down. How about the other leg? Raise that up. Now 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000. You may put it down.
If leg drift is abnormal, document which side is weak, right, left, or both. When assessing sensory arms and legs, make sure all limbs are uncrossed and ask the patient to close her eyes. For the arms, touch the patient on the back of one hand and ask where she feels the touch. Repeat on the back of the other hand. If patient felt it on both sides, ask if it felt the same on both sides. For the legs, touch the patient on the back of one foot and ask where she feels the touch. Repeat on the back of the other foot. If the patient felt it on both sides, ask if it felt the same on both sides.
Can you uncross your arms? Now close your eyes and tell me where you feel this. Can you feel this?
Left hand.
How about here?
Right.
Does it feel the same on both sides? Okay. Keep your eyes closed. Where am I touching you?
Left foot.
Okay. Now,
Right foot.
does it feel the same on both sides?
Yes.
Thank you.
If the patient has abnormal sensation, document which side has the sensory loss, right, left, or both, for both the arms and legs. Assess coordination of the arms and legs at the same time. In the arms, ask the patient to touch your finger with one finger, then touch her nose with the same finger, and repeat the process a couple times. Observe whether her finger touches the target accurately and moves smoothly. Repeat with a finger on the patient's other hand. If very ataxic or uncoordinated, protect the patient from poking her own eye. For the legs, first demonstrate for the patient by lifting and moving one leg as you describe what you'd like her to do. That is to say, raise one leg, touch the heel of that leg on the knee of the other leg, and run it down the shin. Then ask her to do it independently. Observe whether her heel touches the knee accurately and moves smoothly. Repeat this with the other leg.
With your index finger, can you touch your nose and then touch my finger? Do it again. Good. How about at the other side? Good. All right. Can you raise your leg up? Move your heel to your knee and run it down your shin bone. Do it again. Other leg, please. Thank you.
If the patient's coordination is abnormal, document which limbs are ataxic, right, left, or both, and arms or legs. For coordination, count as abnormal only if the patient has dysmetria, that is to say, consistently misses the target, or dystaxia, clumsy movement, that is not related to weakness. Do not mark as abnormal if the patient is too weak to perform the test or the limb is amputated. Performing the MEND exam should take no more than 2 to 3 minutes. Here's a demonstration of the MEND exam in 2 minutes and 11 seconds.
My name's Julianne. What's your name?
Lynn.
Can you repeat after me? You can't teach an old dog new tricks.
You can't teach an old dog new tricks.
Good. Can you tell me the month and your age?
May, and I'm 56.
Okay. Now, close your eyes. Open your eyes. Good. Can you smile for me? Good. Now, can you look at my nose and point to where it's moving? Good. Good. Now look at me. Point to where it's moving. Okay. Fantastic. Okay. Now look at my finger and follow my finger. Good. All right. Now, can you raise your arms up like this? Close your eyes for 5 seconds. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. Okay, you can put your arms down for me. Okay, can you raise your leg up for me and hold it there for 5 seconds? It's 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. Good. How about the other leg? Raise that up. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. Okay, good. Now can you close your eyes for me and tell me where I'm touching you?
My left hand,
Okay?
right hand.
Does it feel the same on both sides?
Yes, it does.
Okay, keep your eyes closed. Where am I touching you?
Left foot,
Okay.
right foot.
Does it feel the same on both sides?
Yes, it does.
Good. You may open your eyes. Okay. Now with your index finger, can you touch your nose, then touch my finger? Do it again. Good. How about the other side? Good. All right. Now with your leg, gonna raise it up, put your heel on your knee, and run it down your shin bone. Okay? Now can you do that for me? Okay, other leg. Thank you.
In summary, here is a comparison of the Cincinnati Pre-Hospital Stroke Scale, MEND exam, and NIH stroke scale. Thank you for watching and listening to this presentation on the MEND exam. This has been a DLG Insight production, innovative neuroscience ideas and thoughts on education.